Of the Board of NHS England. As I always say, this is a meeting in public, but not a public meeting, and we're joined today by members of the public, not only physically here at in Skipton House in London, but also watching the meeting online. I have no apologies for this afternoon's meeting, except for Jane Cummings, who has not been able to join us, but will be with us at the meetings tomorrow. And I just need to start by inviting any members of the board who have any interests which are potentially in conflict with any items on the agenda to state so. Are there any declarations of interest? No, because we have in front of us anyway our standing declarations of interest, and we only have one or two substantive items on the agenda this afternoon. I should just explain that. The reason why our agenda is so slender is that tomorrow we will meet in a meeting in common with the Board of NHS Improvement. So the normal items of business that we would bring here, for example, around the financial and NHS performance, we're going to take in common between the two organisations, because that is not only an earnest of intention for our future working together, but also our understanding that we can better understand the issues between the two organisations through a meeting in common. So I should just also explain in terms of the formalities and proprieties of the meeting that there is no fire alarm scheduled for the coming period of this afternoon, so if the alarm does go off, then I will invite people to be led off the premises to a safe place by our staff. So let me start then with the formal business on the agenda. The first item is the minutes of the last meeting. I'm going to ask the members of the board if there are any comments on the minutes. Are you happy to approve the minutes as an accurate record? Yes, you are. Any matters arising? I have no matters arising from the minutes. Okay. Item 2 is the Chair's report, and I have tabled a written copy of the Chair's report, which I hope members of the board have had an opportunity to review. I'd just like to highlight 2 or 3 issues, if I may. The first is the issue around future working with NHS Improvement, and you'll observe that in paragraph 5 I'm inviting the board to formally delegate to the Chair and Chief Executive the authority to approve, after it's been through the Audit and Risk Assessment Committee, any amendments to our governance documents, standing orders, standing financial instructions and scheme of delegation. And my request to you is that you would approve that with effect from now through to the end of March. So this is a transitional approval in order to ensure that we align the necessary changes, the details of our governance arrangements with the changes to our organisational arrangements with NHS Improvement. Now please can I invite you to approve that delegation? Thank you very much. Secondly, I just wanted to draw to your attention the appointments. I'm really delighted to report formally to the board the reappointment of Noel Gordon and David Roberts as members of the board. It's wonderful to have another 3 years of their great expertise, and also to note the other appointments that have been made that I've mentioned. And then the final item, which is the appointment of my successor, to report formally to the board that the government have announced Lord David Pryor to be the preferred candidate to assume the role. That secondly, he has been through the pre-confirmatory hearing with the House of Commons Select Committee, who resolved unanimously that he should be appointed, subject to an issue around his relinquishing of the party whip in the House of Lords. And understand that his appointment formally is imminent, but it hasn't yet finally been made. But we're optimistic that it may be made even today, and therefore we will be having him in role very shortly. And I know the board will join me in providing him with the warmest welcome, and he takes on the role at a critical time in the life of NHS England and NHS Improvement. So I could just ask the board please to note my report, but I'm willing to, of course, happy to take any questions or comments on the report. Right, I shall take silence as assent and move on to the report of the Chief Executive. Simon.
Thank you, Malcolm. I'll be equally brief, given that tomorrow we are in our joint meeting with the NHS Improvement Board are going to be talking about the long-term plan, winter readiness, and the NHS England and NHS Improvement integration process. On which point, just to say that the recruitment processes are now well underway for the senior leadership team. Interviews will be taking place for many of those roles during October, and we will have a fuller discussion on that tomorrow as well. Since the summer break, September, as usual, I just report on some of my sort of external activities. With Kate Davis, I spent some time at the Heathrow Immigration Removal Centre, looking at the healthcare contribution that the NHS is making in the secure estate inside IRCs, at the RVI in Newcastle, at Christie Cancer Hospital in Manchester, with a large group of local authority chief execs through the format of the Local Government Chronicle Summit, and at Expo and our own NHS England annual general meeting in Manchester, where I took the opportunity particularly to record our thanks, Malcolm, since I think this is going to be your last public NHS England specific board meeting for your leadership of this organisation. There will be other opportunities for us to mark that moment, and no doubt we'll reflect on that tomorrow as well. And also, I think this is going to be the last public board meeting for Paul Baumann as our CFO. And I think it goes without saying that the diligent and thoughtful and surprisingly humorous contributions on occasions that Paul has brought to this board, as well as, frankly, to the stewardship of the finance function across the National Health Service. Without him, we would not have made anything like the progress that has been made over the last, well, certainly the last 5 years, but service in the NHS, which goes back way before that, including for the NHS in London. So although he is now answering to a higher authority than even the NHS England board, he goes with our very best wishes and great thanks. Yeah. And that concludes my report. Although actually, if you're wanting more, Malcolm, I mean, perhaps I should say, I mean, there are 3 other important facts that will perhaps have escaped the board's notice if we're wanting a little uplift at this point of the afternoon. The suicide rate is at its lowest for men since 1981. The tuberculosis rate in England is at its lowest level since 1990. And over the last 10 years, the NHS has reduced its carbon footprint by nearly 19%, while expanding the healthcare activity done in this country by more than 27%, equivalent to a carbon reduction of a small country. So there we are, 3 interesting facts that may have escaped your notice that are worthy of the board's reflection and consideration.
That's wonderful. Thank you. Thank you for that. And those very qualities that you've mentioned of Paul Baumann will be put to the test on a future item on the agenda today. So, on that note, are there any questions or comments for Chief Executive on his report? No. Okay, thanks very much. Thank you, Simon. Let's move on then to the substantive item around the cancer programme. First of all, I've got to record to the board the apologies of Carrie Palmer, who's our National Cancer Director, clearly has been leading on this programme, but she's got an unfortunate conflict today with the annual general meeting of her own organisation, and she felt, although it was obviously a difficult call, that her first loyalty was to her principal employer. However, all is not lost, because we have Matthew Swindells, who will lead for us on the paper, and he's been joined by Joe Cotton, who will, as necessary, help in the double act. So may we turn to you, Matthew, please, to introduce the paper to us.
Thank you very much, Malcolm, and I think part of Callie's enthusiasm of being her own board is that it will be to celebrate them being rated at the Marsden as outstanding again, which is a symbol of why we have Callie leading our national programmes for us. The board will have seen the paper on the National Cancer Programme, which is one of our key priorities under the 5-year forward view. We're now 3 years into implementing the Cancer Task Force recommendations, and within that context, we are now thinking through what does the cancer plan strategy need to be in the long-term plan. and continuing to maintain it as a day-to-day priority in terms of the way the NHS operates. So I would like to just draw out some of the highlights from the paper, and then Steve will add a few words, and then when you come to take questions, I have Joe with me in case the questions get hard. So it's important to have an expert with me. There is some really good news on what we have achieved so far. Cancer survival one-year rates are now at their highest rate ever in this country. 2015, the survival rate was one-year survival rate was at 72.3%, up just under 1% on 2014. So we are moving in the right direction. We're also making progress on earlier and faster diagnosis. So the number of people who are diagnosed after presenting as an emergency is now reported at 18.5%, which is down 1% on the position 2 years earlier. So that's a sign that we're picking things up through our screening and through our primary services, and not simply as emergency interventions. We've distributed £200 million through the cancer alliances, embedding best practice, including the latest research around prostate cancer diagnosis, and rolling out straight to test for colorectal cancer, halving the number of patients who go into outpatients. And we're running the largest radiotherapy upgrade program for 15 years. So last year we spent £46 million putting 26 machines into 21 hospitals, and this year we will fund another 17 more LINACs across the country. We're overseeing this local implementation through the development of 19 cancer alliances that were established in 2016, and whose job is to bring together clinicians from around the multiple providers that can be part of a cancer network, that can be part of an alliance that's delivering a care plan for a patient and ensuring that we optimise across the pathway. And in order to support that, we are now also collating the multiple data sources that we have on cancer in order to give a single view on the care that we deliver. We work in partnership with Public Health England, who are leading on kind of the key causes of cancer, including diet, exercise, smoking and alcohol. And smoking is now down from about 25% in 2004 to 15% in 2017. It's still the biggest avoidable risk, but that is a very spectacular reduction in smoking prevalence in the UK. And we are diagnosing more patients more quickly. So the highest ever number of patients diagnosed at stages 1 and 2, of course improving our ability to get good outcomes from treatment. We are in the process of running the procurement in order to roll out the fit bowel screening in order to, which should happen from this autumn. And we are putting in place now a new faster diagnosis standard of 28 days from referral through to diagnosis or an all clear, which we will be implementing in shadow across the country next year, and then formally starting to publish from April 2020. We have a number of big innovations alongside the LINACs. We have the 100,000 Genome Project, which the Chairman's been very involved in, which is a world-leading programme, and we were very pleased to announce only a few weeks ago the adoption of CAR-T therapy for suitable children and young people with acute lymphoblastic leukemia, which we are hoping the first patients will start to go through in the next few weeks. And we're working to develop with HE our cancer workforce. HE published a cancer workforce plan for the first time in December 2017. We are targeting the most stressed clinical areas for increasing the workforce, and investing in another 200 endoscopists on top of the 200 additional ones we put in place earlier. So we now have 128 new endoscopists have come through training. We have 300 more reporting radiologists going through training and new apprenticeships. And we've tried to use the programme to focus on inequalities as well. So we're targeting lung survival the lowest rates of lung cancer survival with new low-dose CT screening, and we are implementing our rapid diagnostics for lung, prostate and colorectal cancer in the most deprived communities and in BME communities that have high rates of these diseases. So there is a focusing on trying to hit the areas where we can have most impact. In the context of all of that fantastic progress, we do need to note where we are on performance, that in the last month we have seen, from having, through enormous efforts last year, got our 62-day cancer target performance to 84.7% against the target of 85%, which involved a lot of cancer alliances working and redesigning pathways. We have seen that drop very significantly, now down to the high 70s, and which initially took us slightly by surprise. But when we look at what is driving that, we've seen the first 3 months of this year a nearly 14% growth in the number of cancer referrals, and that incorporated in that was a 30% growth in urology referrals, primarily prostate cancer referrals. The NHS responded across April to July by delivering the highest number of treatments that it has ever done, that is ever achieved for 62-day cancer, a 10% increase in the volume of treatment. But that gap between a 14% nearly increase in demand and a 10% increase in what we were able to supply did cause the performance to drop to 78%. So we are putting in place a program because we are in it is an interesting challenge for the NHS because we are very actively campaigning for people to come forward with their suspicions of cancer earlier. Our ambition to improve cancer survival rates requires us to see more people, get more people through diagnosis and get more either all clears or getting people onto treatment pathways. That kind of a spike in demand, though, exceeded our ability to respond to it. So we have committed £10 million across the country to go out and address the backlog that has been created in that, whilst we continue to do the work around expanding the workforce, expanding capacity and redesigning pathways to allow us to provide the quality of service that we want to much larger numbers of patients. So I would hate that to think that we considered this spike in demand to be a problem, because it is good news and people's lives will be transformed by the fact that they came forward. But that's a really big increase in a very short space of time. So we're spending money in order to address that backlog. We are targeting support to the most challenged systems, and we are accelerating the introduction of best practice. But this month's cancer performance, and in all probability for the next couple of months as we do the work to turn this around and get more capacity in, is not where we want it to be, even though we've treated more patients within 62 days than the NHS ever has for the last couple of months.
Great,
thank you.
Matthew. Steve.
Thank you, Malcolm. Well, I'll try and echo what Matthew said without duplicating what he said. But I think in many respects it's a really exciting time for the cancer programme. And I say that because we're moving to an era where we are seeing really interesting possibilities around the treatment of cancer. So you've mentioned CAR-T, which is an immunotherapeutic-based treatment of childhood leukemia in the first instance. And as somebody who actually, at my very earliest career, was an immunologist, and I remember tumour immunology having the promise of something but never quite really managing to deliver, this is a real manifestation of how that science has led to a treatment which is radically different and life-changing and life-saving for a population of our youngest patients who for whom the treatment options were very much more limited. And I'm absolutely delighted that we were able to announce recently, and Simon announced this at Expo, that we will be able to introduce this to the first patients in the UK, in England, in the next few months. I think the 100,000 Genome Project is another area where we are beginning to see the promise of genomics And as that program expands and genomics then develops on the back of it, the information that we will gain around the individual mutations in cancers will be transformative in our approach to managing cancer. So I think when we think of the next 10 years in terms of the next 10-year plan, it's a really exciting time to plan for. It's equally true that, as you said, our cancer survival, our detection rates are better than ever, but we still have more to do. And we have more to do at the beginning of the cancer journey in terms of diagnosing people earlier and more promptly, and we know that that is an area where we need to do better. And again, you've already highlighted a number of the initiatives that we have to do that, including case finding for lung cancer, the new bowel screening program, which we believe will have a higher uptake and will encourage people in groups who maybe before have not participated in that program as much as we want to participate. So there is lots of good stuff going on, but we need to do even better. And so I know Joe and the team, when they think about the 10-year plan, are really thinking about how we can really shift to early diagnosis, because we know that fantastic though the treatments are for people with cancer, actually the earlier we catch it, the better the survival. And so I am confident that as we shape the next 10 years, that's where our focus will be.
Thank you, Steve. Now, any questions, comments from around the board? Moira, please.
Thank you, Malcolm. Obviously, very encouraging, positive report, but from NHS England board point of view, is there an opportunity to give us better comparative data? Because often we read things in the press and we think that's fantastic, and then you see a comparative figure for other health systems and you think, wow, we've still got a long way to go. So I think that's not just about this report but and cancer, but more generally, how do we measure, in a sense, how well we're doing otherwise? And secondly, is there evidence of the benefits of the reduction in smoking? I was really surprised at the smoking rates now. I think that's a fantastic development, really. But is there, can we point to the impact of that anywhere in the figures generally?
Yeah, so in terms of international comparisons, a lot of the international comparisons data that's used in the press and that we know about is actually quite old. It's from sort of a few years ago, maybe 10 years ago, but there's an international cancer benchmarking partnership that England is part of, that's really looking at the data, trying to make the data as comparable as possible, and also looking at the causes and the reasons for any differentials, particularly has focused on the differences with early diagnosis rates between countries. So we're an active player in that, and we're expecting the latest reports from that partnership this year, so that can be shared then with the board. In terms of smoking rates and seeing the impact, we know that it will take a few years for that to impact in terms of survival rates, but you'd expect that to be most notable in lung cancer and lung cancer survival to improve, but it will affect other cancers as well, but it will be some years until that's seen.
But we work across CVD as well.
Yeah.
Have a dramatic effect.
We should say that as we look at kind of what makes a difference, and as we're working through into the long-term plan, undoubtedly part of what's going to come out of that is access to some of the diagnostic facilities. So we have very low numbers of MRI scanners in this country. It's increasingly an important diagnostic tool, and so the focus on earlier diagnosis, getting access to the right diagnostic equipment, and being able to move increasingly to direct test referrals for patients rather than bouncing via an outpatient appointment and then back out to diagnosis, will all allow us to identify cancers earlier, which allows us to start our treatments more quickly. And I think generally, as Joe said, our view is that where our survival rates are poor compared to some countries. That is largely to do with the speed at which we diagnose, hence why we have to encourage more people to come forward rather than the quality of the treatment once we've identified it.
And one of the key things that International Cancer Benchmarking Partnership has shown is the reluctance of people in this country to go to their GP when they have symptoms of cancer. So it's really important that we do continue campaigns like the Be Clear on Cancer campaigns to encourage people to come forward with symptoms.
Thank you. Joanne?
It's a perfect introduction, really. I was very pleased to see the item in your report about the Be Clear on Cancer campaigns. And I had a couple of thoughts about that. I mean, first of all, I was wondering how we assess the effectiveness of those campaigns. And secondly, I'm particularly thinking about the new fit bowel screening test, which, as Steve was explaining, you said, Steve, that you believe that we'll have a higher uptake for that. Whether there's an opportunity for us to use more conventional consumer marketing techniques to identify those communities, often disadvantaged communities, where uptake's lower, people don't come forward, to really understand what approaches and messages will resonate with them, and then crafting campaigns to really target those communities which have the greatest opportunity to benefit.
Yeah, absolutely. So in terms of the way that the campaigns are evaluated, so they're fairly robustly evaluated, and they look at so you look not only at awareness levels and whether those have been raised during the campaign period, but also on processes and outcomes. So have we seen an increase in people turning up to their GPs, an increase in subsequent referrals, but also those conversion rates to diagnoses of cancer. So those are assessed when the campaigns are run. In terms of using the latest marketing campaign techniques. So Public Health England, who run these campaigns, do continually look at making the best use of modern marketing techniques. So I know social media may not seem the most modern now, but as that was being introduced, they were looking to exploit that to reach communities who weren't otherwise receiving messages. But they've also been trialling campaigns targeting specific groups of people. So with prostate cancer, that was more prevalent in black men. They had a pilot campaign that particularly targeted messages towards that group as well.
It would be really interesting to see some of those results, actually.
Yeah, of course.
So thank you very much, that's great.
And we do know that people use the materials that we create. So when we had the news coverage on prostate cancer back in February, the increase in number of people coming to the prostate cancer webpage on the nhs.uk website went up from 40,000 to 90,000 people, and that converted into a 30% increase in the number of people being referred in for testing. So there is a desire out there in the public to be able to. It's really about putting it front of mind, and then they will go and find the information, and then when they have the information, they will go and see their GP and get into the pathway. So I thought that pathway is interesting, and it is important that we have easily consumable information that's targeted at the right groups, because I think people do want to know.
Further, Michelle.
A number of the national programmes, there are several issues raised about workforce. I just wonder if you could talk us through any of the challenges with workforce with this programme.
You happy?
Yeah. So as Matthew said, the Health Education England published the first cancer cancer-specific workforce plan in December last year that picked out a number of priority professions which are listed in this paper, particularly around the diagnostic end of the pathway, where there are issues in capacity, and we really need to take actions to increase the numbers in those professions. What we've been looking at, and since that was published, Health Education England have been working with and through our cancer alliances to look at on the ground what actions are being taken, particularly by trusts, to identify their gaps in capacity and take actions to fill them. What we are doing as an important step in the long-term plan is looking not only at the gaps in numbers, but how those pathways need to be structured differently and how we can use the workforce more effectively, particularly within areas and across systems. So really emphasising the importance of alliances and alliance working, but how we can use the workforce more effectively. So that's an important part of the long-term plan as we sort of work with Health Education England to address those capacity gaps at the moment.
I think it's an important piece. A couple of things I think in there. One is cancer is sharing diagnostic equipment with the rest of the NHS as well. So we need to think about not just what we need for cancer in terms of MRIs or endoscopies or whatever we need to make sure we get the volumes and the people right for the whole of the service. And I think the other is to make sure that we are using our workforce as effectively as possible. I had the deep joy a couple of days ago of being at the St John Ambulance annual awards dinner, sat between two 55-year-old men talking about their screening experience. One of them had their endoscopy done by a specialist nurse, one had it done by the consultant. You go, well, why have we got consultants doing endoscopy still in some of our hospitals? Why are we not making sure that people are working at the top of their licence? And so I think we still have variation in practice across our organisations as well.
But we do know that it's such an important issue. The engagement we've been doing over the last month on what should go into the long-term plan for cancer workforces, the second priority only after early diagnosis that has come out for us. So we know how important it is.
I just want to check, Steve, whether your intervention was on that point. Okay.
Also related to the operational pressures point that Matthew had made earlier. So the operational pressures, which I'm sure we will talk a bit more about tomorrow, is for a reason that in one sense is a good reason, as Matthew's outlined, in that having more patients to put through cancer diagnostics and pathways because more people who may have cancer are being referred in is a good challenge to deal with. But on the staff side, it obviously puts a lot of pressure on our cancer teams, our primary care colleagues to refer in. I think we should say thank you to those staff, because I know how hard they are working to ensure that we do manage patients as swiftly as possible through that particular process. So I think it's a operational pressure, but yes, it's because we're seeing patients earlier. And just on that point, one of the things that's in the paper, but I just wondered, Joe, if you could tell us a little bit more about it, is one of the reasons that we might not detect cancer as early as we want to is because people with non-specific symptoms that may not obviously point to one cancer or another take longer to get into a diagnostic and a specialist system. And the multi-specialty clinics, the multidisciplinary clinics that are in this paper that we have set up, 10 of them, specifically to see how we can do that better, have been rolled out during the year. And I just wondered if you had a sense of how that's going and how well they're doing.
Yeah, absolutely. So these have been really getting underway this year. So set up in the last financial year and then really getting underway this year. The results from those pilots are really encouraging. And this was mentioned elsewhere in the board, but not just for cancer, but actually in picking up other diseases as well, and putting people onto treatment pathways. We are really encouraged by the success of the pilots and want to build on that model, which has been so successful in other countries, like in Denmark. So thinking about international comparisons. Want to build on that in the long-term plan. So to think about how we can extend those pilots to other areas in the country, but also think about how we can involve more people and more patients going through that route, so that they're not, as you say, not bouncing around between primary and secondary care and getting a swift diagnosis.
David.
So it builds on this same theme, which is really, we're clearly, it's in everyone's interest to continue to get more people to come forward, and yet we have, that then creates challenges in terms of then managing that, and obviously the longer people wait, the more upsetting it can be. So it's in everyone's interest as well to try and shorten the diagnosis time. I know nothing about the detail of how this works, so please excuse me if this is completely ignorant. But in the world I come from, we're spending a lot of time on utilising data to drive prioritisation and targeting, and we're using artificial intelligence and machine learning to be able to rapidly improve our ability to turn that data into real insight and information. And it strikes me that in some areas of diagnosis, that parallel is very strong. And I know, for instance, there's the work that's been done in Moorfields with retina scans, and there are many others around the health service. I'd be interested to know to what extent in the 10-year plan we're thinking about more aggressive use of data, machine learning, artificial intelligence in its broader sense, to try and target our workforce, which is our scarcest resource, onto those areas where they're most needed.
So there are huge opportunities in space, and you call out the work that's being done at Moorfields, and I think in many of the laboratory and imaging modalities, you'll see increasing use of AI to give us diagnoses, and in some areas we're already seeing those matching the human diagnostic quality. So and it's still in its early stages. I think it's one thing to do it at that diagnostic end. I think it is equally important to be looking at how do we support primary care in routing patients through and being able to people coming through with, as Steve said, sometimes quite generic symptoms, and helping to guide them to the right set of tests, interpreting those tests and getting them into the right part of the pathway as quickly as possible, both getting people who do have a cancer or a serious urgent treatment to the right specialist as quickly as possible, but also being able to assure and comfort the people who don't have that condition that they don't have cancer, and routing them to the appropriate treatment for those. So I think we are, and I've been talking to Callie a lot about this, is what are the tools that we need to put at the front end with GPs in order to be able to get in order to support that end of the diagnosis, as well as the kind of once you've been all the way through the system and we now have a picture of you.
Good, well, thank you, Joe. Thank you particularly for coming along, and Matthew, and I'm sure Callie will feel that honour has been served in her absence. So thank you very much. Thanks for that.
Very much.
We will, of course, tomorrow be looking at the NHS financial and performance data, and that will allow us, Matthew, to return also to the questions around referral to treatment times. So we'll do that as a joined-up meeting with NHS improvement colleagues. Right, maybe then move on to the very important item, the report by our Chief Finance Officer on the use of the NHS England seal. Paul.
Thank you, and thank you for the invitation earlier on. Wrestling with the finances of the NHS in one of its most challenging, exciting periods for many years means that the life of the NHS England CFO is never dull. Having done it for a number of years, I can definitely confirm that Monty Python got it completely wrong when he said that a move from accountancy to lion taming was an overly ambitious career move. There are, however, two sources of comfort and support in that particular role, one of which, of course, is the frequent occasions I get to sit with this august group of people and exchange ideas about all of the excitements that we are grappling with. The other is the moment of tranquility which comes into my life generally about twice a month, when Leslie here comes into my office with the seal of NHS England, and usually a stack of documents slightly taller than she is for us to grapple with. I have to tell you, not many people have seen the seal of NHS England, and it is a little less impressive than the one that I will have in a few weeks' time. But over the last 5 or 6 years, it has probably done well over £1 billion of business, if you like, for the NHS. And actually, although it is not, as I say, frequently witnessed in so doing, it does some of the most important things that we get to do as an organisation. And this particular set of things in the document is very much in that mould. 38 of the 43 transactions you see in front of you are to do with reshaping our learning disabilities property portfolio, and without the seal, unimpressive as it is, being available to release particular legal holds in various places and assert them in other places and undertake property transactions, we wouldn't be able to do all of the really exciting work that we are doing in that space and a few other spaces. So boring as the report is, and I really can't make it any more exciting for you, this is a report on work which I very much hope the seal will continue to do over the coming years in order to take forward the agendas that it has been supporting for the last 6 years. That's as exciting as I can make it, Mark.
Well, it certainly wasn't dull, Paul. We're very, very grateful to you for the performing seal on behalf of NHS England. Yes, sir. There was a
First time ever.
Please, the Chief Executive.
I mean, there must be a backstory, possibly even a cover-up, Paul, in relation to item 351. What's the story?
It was. It is not ready to be enacted. That is the simple truth. It just didn't get through in time.
And I must say, the Chief Financial Officer said that without moving his lips. Extraordinary.
The great virtue of leadership is that you work with people who know what they're talking about.
Indeed.
And my friend here keeps such a meticulous record of all the things that are ever put into the seal system to be transacted that you cannot get something off the list even if you wanted to. Which means if you don't quite get round to doing it, it appears as the slightly anomalous item that you picked up, Simon. But I'm glad that you've read the paper at least.
No, item 378. 23 Pocahontas Crescent, Indian Ocean, St Columbus in Cornwall.
There are some impressive names in this.
Wonderful names.
I think we may have driven the seal almost to extinction on this item of business, but Paul, thank you as always for a most informed outline of its use. Maybe then move on to the next item of business, and I welcome Chief Nursing Officer Jane Cumming to the meeting. Jane, just in time for the reports from the board committees, although you've just missed the seal. The first of these is from Commissioning Committee. Wendy, anything to add to the report that we have in front of us?
No, I think the report really covers what we do. As you know, the Commissioning Committee, which met on June 28th and actually met again yesterday, really dives into the operations and the finance area of the NHS. So we spent quite a lot of time in the June meeting, both understanding the integrated care systems and what that meant and how that project and program was developing, as well as a number of the national programs, with quite a large audience exploring those issues. There was a point I would like to bring to the board's attention to note, which was we also looked at the 2017-2018 improvement in assessment outcomes for the clinical commissioning groups, which is something we do every year to understand how we think about the CCG's performance and create a framework for managing it in the year forward. So we did that. So we both approved the ratings for the 2017-2018 framework. And obviously the implications of that are that CCGs that are rated inadequate will go into special measures, and that some of those CCGs that are rated requires improvement will maintain or have to enter into special measures. And we also talked about the go-forward indicators for the IAF framework, including a number of new indicators for the year ahead.
Thank you very much, Wendy. Any questions, comments? No. Thanks very much. Shall we then move to SpecCom? No?
Well, I don't think I can add very much more, Malcolm, than is in the note already.
Okay. I don't pick up any questions or queries to Noel. Right. Well, that brings us to, I think, the conclusion of the formal business and to Eric, yes. Anything, Joanne?
Yes, thank you, Malcolm. I would like to, offer to answer any questions about the paper, but also to just take a moment to say a few more words about Paul on behalf of ARAC. So what's really been clear to me in the course of the process to find Paul's successor, it has reminded me about the scope of the responsibilities that Paul has carried on behalf of this organisation and of the NHS, that he's been, in part the architect and the person thinking about the strategic funding and finances of the NHS. He's been an advocate for the funding that the service needs. He's been the financial controller-in-chief, and he's also been the leader of the finance profession through the NHS. And the enormity of that role, I think, is often not fully appreciated because of the effortless finesse with which he has carried those responsibilities. So thank you, Paul. And I would just like to say, in case any of the candidates to replace him happen to be watching us on video, that to emphasise the absolutely fun nature of the audit committee and what a delightful experience that is.
Well, thank you, Sharon. May we also invite the board to ratify the committee's approval of the updated scheme of delegation, and also to, of course, ratify everything that you've just said about Paul. So that, I think, does bring me to any other business, which is simply on behalf of the board to express our immense thanks to Paul. I think everything that's been said today is wholly recognised right around the boardroom table, and not just around the boardroom table, but throughout the organisation. So, Paul, you've done a wonderful job. You're going to the higher seal in your new role, which I know you will bring enormous learning and wisdom and great distinction to, and we wish you all the very best in that new role.
Thank you.
Thank you for all you've done for us.
Thank you very much.
Okay. Well, thank you very much. On that note,
Sorry, Malcolm, before you go any further, it is also your last public board meeting, which Simon mentioned before, and it would be wrong for us to not conclude the meeting by a huge vote of thanks to you. Now, NHS England didn't exist when you first came along, and I think it was a few people in a room, and you've actually, I think, overseen one of the biggest merger programmes that's ever been undertaken in the UK, with many hundreds of statutory entities coming together. You've built a team, you've built a board, you've built a strategy, and we're now in the process of executing that strategy. So I think your 7 years, 8 years, 7 years? 7 years has been a remarkable effort. So there will be many other occasions where the board will be able to say thank you, but I think it's entirely appropriate that we say thanks to you here today. The one thing that you have fundamentally failed to do, however, is to sort out the heating in this building. So those of you watching on the webcast will note that particularly the ladies amongst us have wrapped up in their shawls, but also the rest of us gentlemen have our coats wrapped around us, apart from our good friend from Yorkshire here, who is showing us what the world is really like. But I have yet to work out whether that is a cunning plan to keep everyone focused, sharp and awake, and to keep the meetings short, or whether it's part of the efficiency regime. But you will no doubt be handing over the key that controls the temperature to David Pryor when he turns up. But Malcolm, you've been an outstanding chairman. You will continue, I think, to be engaged in the health system in a number of different ways. We will miss your counsel and your humour, and on the first of what will be many occasions, and there's still a month to go, to say thank you ever so much and to wish you well on behalf of the board.
Well, thank you, David, very much for those very generous remarks. And I have to say, the heating is not the only unfinished item of business. And with the NHS, there's never any finish to the items of business. It's an ongoing enterprise of huge importance to the nation. And it's been an enormous privilege to be able to serve in this role. So thank you very much for your comments, and to everybody for your warm support over those years.
A warm support?
Yes. I'm going to invite you to pass the necessary resolution to proceed to private business, and I declare the meeting closed. Thank you all very much.